And welcome to Insight Ophthalmology. This is Dr. Amrit, and today we are discussing a very important topic, that is axis of eye and important angles which are present in the eye. And before I go into the topic, I would like to ask you a few questions. Okay, the first question is the angle between the optical axis and the visual axis at the nodal point of the eye is called as, and options are angle alpha, angle theta, angle kappa, or angle gamma. Okay, so I'm not going to tell you the answer, but this is the first question. And the second question also, which is most commonly asked, is regarding angle kappa, which of the following is the correct statement? Number one, angle between the optic axis and pupillary axis, or positive angle kappa is seen in myopia, or is it the angle between the pupillary axis and visual axis, or positive angle kappa gives appearance of pseudoesotropia. Now, if you know the answers to these questions, you can write it in the comment section. And even if you don't know, just go through the video, and I'm sure that by the end of the video, you'll be able to answer the MCQs. Now, let us start with the important axis of the eye. So basically, there are three axes of the eye that we should be aware of. Number one is the optical axis. Number two is the visual axis, and the third one is the fixation axis. Now, before I start telling you about these axes, the optical axis is also called as the anatomical axis. And there are a lot of people who also call optical axis as the pupillary axis. So this is very important point that you should remember, that optical axis is also called the anatomical axis, also called the pupillary axis, right? So first thing is, what is meant by this optical axis? Let us see. If we take an eye and we draw a line which is passing through the center of the cornea, and let us label it as P, and that line has to pass through the center of the lens, let us label it as N, and then it has to pass straight and meet a point on the retina R. Alright, so why am I calling it P and N is because the center of the cornea is usually the pupil, and therefore I am representing it as the P. The center of the lens is usually called the nodal point of the eye, and therefore it is represented as N. And this line, when it is passing through the center of the cornea, through the nodal point and meeting on the retina, therefore I have represented it as R. Here what I want you to know is that this is retina. I am not calling it as the fovea. Okay, there is a difference. Okay, so this line is called the optical axis. Okay, so let us see this on the diagram over here. The line, if we draw a line which is passing through the red line over here, which is passing through the center of the cornea P, passing through the nodal point of the eye N, that is center of the lens, and then going on to the retina at a point R, and this point R is nasal to the fovea. Such an axis is called the optical axis, also the anatomical axis, and since it is passing to the center of the pupil, it is also called the pupillary axis. What is important to know is that this optical axis is not passing through the fovea. It is passing at a point which is nasal to the fovea. Okay, and I hope it is clear, because see, you can see over here that this is the optic nerve, and we all know that optic nerve is present towards the nasal side and the fovea is present towards the temporal side, and the line that is the optical axis is passing somewhat nasally to the fovea. Okay, so this is your optical axis, right? Next is, what is meant by visual axis? Now, if we consider a point of fixation, say over here, let us consider this point of fixation as O. Okay, and from this point of fixation, if we draw a line which is passing through the nodal point of the eye and then going and meeting the fovea. Okay, so this axis would be called the visual axis, the axis which I have drawn over here in green color. Okay, so visual axis is nothing but whenever we are looking at an object, say O, the image will be formed on the fovea, right? This line, when we draw this line joining the point of fixation, that is O, passing through the nodal point and reaching the fovea, then this line is called the visual axis, the green color line. I hope it is clear, right? Then you will ask, okay, fine, optical axis we know, visual axis we know, and the third axis, which is not that important, is the fixation axis. Fixation axis is nothing but if we take a central point inside the eye, which is called C, and this point is called the center of rotation of the eye. Okay, this is called center of rotation of the eye. And if we draw a line passing from the point of fixation through the center of rotation of the eye, then this line will be called the fixation axis. Okay, but for the purpose of MCQs and for the importance sake, I will tell you that you should know what is an optical axis and what is a visual axis. These two axes are important. Okay, and second thing what you should know is that optical axis is also called the anatomical axis, and for to make it easier to understand, it is also called the pupillary axis. Okay, so this is about the axis of the eye. Now let us come to the important visual angles of the eye. Okay, just like the axis of the eye, there are three main visual angles: angle alpha, angle kappa, and angle gamma. Out of this also, it is the angle kappa which is the most important, and we will be discussing about this in detail. Okay, so let us see this image, and based on this I will try to explain you about these angles. Now the angle alpha is nothing but it is the angle which is formed between the optical axis and the visual axis. The optical axis over here is represented by AR and the visual axis is represented by OF. Okay, so let me draw it for you over here. So this is the optical axis and this is the visual axis, and they're crossing at a point where? At the nodal point. So the angle which is formed at this nodal point is called the angle alpha. All right, next is, what is angle kappa? Angle kappa is the angle which is formed between the visual axis, that is the OF here, and the optical axis, right? But here the important point is not at the nodal point, because what is formed at the nodal point is angle alpha. Okay, so with respect to angle kappa, we take the angle to be formed at the level of the pupillary plane. Okay, so which you can see over here at P point, right? So that is angle kappa. So this is the only difference between angle alpha and angle kappa, that alpha is formed actually at nodal point and kappa is formed at the level of the pupillary plane, right? So in your MCQs also you have to be very careful. Usually if they give you that the angle is formed between the optical axis and the visual axis, that could be the answer for angle kappa also. But specifically if they are asking at the level of the nodal point, they are testing you for angle alpha. At the same way, sometimes they might, instead of telling optical axis, they will tell the angle which is formed between the visual axis and the pupillary axis, right? So in that case also you should not get confused, and you should know that the pupillary axis is also called the optical. Now coming to the angle gamma is the angle which is formed between the optical axis and between the fixation axis and formed at the center of rotation of the eye, right? So angle, for the purpose of your MCQs and entrance, angle kappa is the most important, and remember that angle kappa is the angle which is formed between the pupillary axis and the visual axis, or you can also call it as optical axis and visual axis. right? But specifically if they are asking you at the level of the nodal point, then you have to consider angle alpha. Otherwise, angle kappa is the answer to the question. Now, let us talk a little about angle kappa and its importance. Okay, so first thing I want to tell to you is that whenever we shine a torchlight into a patient eye, the reflex that we see is not exactly in the center of the pupil. It is seen somewhat nasally. Okay, so this will be about 5 degrees, right? And why does this happen? This happens because of the normal angle kappa, which is about 5 degrees in normal adult, and in children's it is about 10 degrees. Now, why does this happen that the reflex is present on the nasal side? Let me see. Let me tell you. So, as we have already seen, the optical axis or the anatomical axis, or for the sake of easy understanding, the pupillary axis is passing through the center of the pupil, the center of the lens, which is the nodal point, and on a point on the retina. And the visual axis, on the contrary, is passing from the point of fixation to the nodal point and then going towards the fovea. Now, our fovea is present on the point temporally to the optical axis, or we can say the optical axis is ending at a point which is nasal to the fovea. So, as the fovea is present temporally, and we know that the object and images are present on the contralateral side. What I mean to say is that if we are seeing something on the nasal side, that will be represented on the temporal retina. And if we are seeing something on the temporal side, that will be represented on the nasal retina. Similar way, because the fovea is present on the temporal side, the reflex will be present on the nasal side. Okay, and this happens because of the difference between the visual axis and between the optical axis. If these two axes were equal to each other, what I mean to say, if fovea was present, this F point was present instead of in place of the R point, then these two axes would be coinciding. That means the pupillary center would be actually equal to the reflex point, right? But that does not happen because there is a difference between this visual axis and between the optical axis as angle kappa. That is the reason we are seeing the reflexes onto the nasal side, and that is the reason we have about 5 degrees difference of these reflexes, or 10 degrees in case of children. I hope this is clear. Yeah, so in certain conditions there are certain anomalies, or this angle kappa will keep on changing, will differ from the normal variant. So normally we know it is about 5 degrees. Now in certain conditions, what will happen is, if the visual axis is deviated more away from the optical axis, what will happen to the angle kappa? The angle kappa will become large. Okay, and this large angle kappa can also be called positive angle kappa. And what will happen to the value of the angle kappa? It will be more than 5 degrees. But also there can be certain conditions in which this visual axis might shift towards the optical axis. Then what will happen? The angle kappa will become smaller, right? And that smaller angle kappa, we can also call it negative angle kappa. Why? Because sometimes it will move toward this side and then it might become 0. The difference between them might actually become 0 when they both will coincide, and then the visual axis might actually cross over the optical axis and become negative. So in such a case, the angle kappa will be now less than 5 degrees. It will be even more less, right? So that can also happen. Okay, so now let us see, where will you see a large angle kappa and where will you see a smaller angle kappa. Okay, so let us talk about in myopes, what happened in myopes. Imagine this was our optical axis, which was passing through the center of the pupil, the nodal point, and a point R, which is nasal to the fovea. So this was our optical axis. And then we have another axis which is passing through the fovea, and this is the visual axis. And the angle between the two is angle kappa, okay, at the level of the pupillary plane. Now what happens in case of myopes? Okay, let's see what happens in case of myopes. We know that in myopia there is a temporal stretching of the retina. Okay, there is a temporal stretching of the retina. So what I mean to say is that this part, this is the temporal part, this will start getting stretched. Okay, so as this part is getting stretched, the fovea will be shifted more nasally, right? So in myopes there is a nasal shifting of the fovea. So what happens? Because there's a nasal shifting of the fovea in myopes, that means the fovea is coming now closer to the optic disc from its initial point. So what will happen now to the visual axis? The visual axis will also become closer to the optical axis. So what has happened now to the angle kappa? The angle kappa is smaller. Okay, this smaller angle kappa can also become 0 and then it can become negative also. Okay, so what happens in myopia? In myopia we see a smaller angle kappa. Okay, so we see a smaller angle kappa in case of myopes. Okay, now what will happen if we talk about hyperopes? Okay, hypermetropia. Let's see. So in hypermetropia also similarly, this was our optical axis and this was our visual axis which is passing through the fovea. Now in our hypermetropes, the eyeball will be now smaller. Okay, and because the eyeball is smaller, a mechanism opposite to that of the myopics will occur. That means the fovea here will be shifted temporally. Okay, so there will be a temporal shifting of the fovea in case of hypermetropes. Now because of this temporal shifting of the myopia, what will happen? The new visual axis will also be much more far away from the optical axis, and because of that the angle kappa in case of hypermetropia will be a larger angle kappa, or it will be a positive angle kappa, or it will be more than 5 degrees. Alright, so I hope this is clear to you. Okay, next what I want you to know is the concept of pseudoexotropia and pseudoesotropia. So let me explain them to you one at a time. So what happens in a normal eye? In a normal eye, we know that whenever we are shining the light, the reflex is actually formed somewhat nasally based on the angle kappa, right? In the eyes which are looking straight ahead. Now what will happen in case of hypermetropic eye is, as we already know, that the angle kappa will be more. Now because the angle kappa will be more, this reflex will now be shifted more than 5 degrees nasally. That means it will look more nasally compared to normal. And if the eye is looking more, if the reflex is more nasal, we might think that the eye is actually shifted outwards. And we might think that there is an outward deviation. And that outward deviation is called exodeviation. Okay, so it will look as if the patient has an apparent exotropia, and because this is apparent and only because of the large angle kappa, this exotropia is called pseudoexotropia. Okay, so pseudoexotropia is seen in case of hypermetropia. Similarly, if we see in a case of myopia, what will happen? In myopia, we told you that because of the temporal stretching, the fovea will be shifted nasally and the angle kappa will become smaller. So if the reflex was present nasally now at 5 degrees, it will be shifted more temporally now in these patients, more toward the center, and then again if it becomes negative, even more it will be shifted temporally. So it will give an appearance as if the eye is actually shifting inside, right? So it will look to us as if it is a inward deviation of the eye. And because this is also just an apparent inward deviation because of the smaller angle kappa in myopes, this is called pseudoesotropia, right? This is called pseudoesotropia in the case of myopes. Okay, yeah. Next, I want you to know about various conditions in which we can have pseudoesotropia or pseudoexotropia. Pseudoesotropia is a condition where esotropia is not present, but still it looks as if the eyes are shifted inwards. Okay, it looks as if the eyes are shifted inwards. It is only a deception. That is why it is called pseudoesotropia. So pseudoesotropia is seen in case of high myopia. Okay, and why it is seen in high myopia? Because of the negative or a smaller angle kappa. Same way, it is also seen in a condition which is called telecanthus or epicanthus. So let me explain it to you how. If this is a normal eye with normal eyelids, the eye will look to be in the center. In a case of epicanthus, an extra fold will be present over here. Because of that presence of extra folds, okay, it will look as if the eye is more closer towards the canthus and will give an appearance that the eye is esotropic. Because of that, epicanthus is also one condition in which we will feel as if there is pseudoesotropia present. Similarly, in patients who have closer set eyeballs, that means closer IPD, normally the distance between the two pupils is about 60 mm. In a patient who has less than 60 mm also, we might feel as if the eyeballs are closer, right? So in such conditions also, it will look as if he has pseudoesotropia, right? Similarly, there's one more condition which is called telecanthus. Now what happens in telecanthus? Telecanthus is nothing but, in a normal eyeball, the distance between the two pupils, as I told you, is about 60 mm. And the distance between the two canthi is about half of 60, that is 30 mm. In telecanthus, this distance will increase, that means the intercanthal distance will increase. However, the interpupillary distance, that is about 60 mm, will be normal. Now, when the two eyes are actually at the same location, their pupils are also at the same location, just that their canthus distance has increased this distance. Again, it will look to us as if these people also have close set eyes or pseudoesotropia, right? So to enumerate, the causes of pseudoesotropia are high myopia, negative angle kappa, epicanthus, telecanthus, or a small IPD or interpupillary distance. Similarly, what are the causes of pseudoexotropia? Remember, pseudoexotropia causes are hypermetropia. Okay, and why do we see pseudoexotropia and hypermetropia? Because of a positive angle kappa. Okay, and why do we see a positive angle kappa in hypermetropia? Because the fovea was shifting temporally. Okay, and the distance between the visual axis and the optical axis was also increasing, and therefore the angle was increasing, and therefore it was giving us an exotropic appearance, right? For the same reason, we see pseudoexotropia in retinopathy of prematurity also. So in retinopathy of prematurity also, there will be a temporal shifting of the fovea. The fovea from normal position will shift towards temporally, and it will cause change in the visual axis and therefore angle kappa, and therefore the patient will seem to have a pseudoexotropia, right? Yeah, and hypertelorism is one more condition in which we will see the pseudoexotropia. So what is hypertelorism? I've already explained it to you what is meant by telecanthus. So in telecanthus, as we knew that in telecanthus, the IPD was normal and the ICD, the intercanthal distance, was actually increasing, right? Whereas in hypertelorism, the IPD will also be more than 60 and the intercanthal distance will also be increasing. So everything is increasing. So obviously it will look as if the eyeballs are more far apart. So it will give us an appearance of exotropia, outside deviation. Okay, exotropia. Similarly, if a patient has IPD which is more than 60 degrees, 60 millimeters, then also it will give us an appearance of pseudoexotropia, right? So it is very important for you to know when do we see pseudoesotropia and when do we see pseudoexotropia. Okay, so these are the causes of pseudoesotropia and pseudoexotropia. Next, many of you might ask that whenever we examine a patient, we only see a reflex, and based on the reflex, we will be telling whether it is eso or exo, right? So how do we tell whether it is a pseudo squint or it is a true squint? Okay, so based on the test, which is cover test. So always you have to do a cover test whenever there's a squint, and if there is a movement, redressal movement seen on this cover test, okay, if there is a redressal movement seen on the cover test, then it is a true squint. But if there is no redressal movement seen on cover test, then it is a pseudo squint, okay, or the pseudoexotropia or pseudoesotropia. Now the question that I have for you, one more question, is why do we not see any redressal movement in pseudo squint? Okay, so this is a question for you. Next, coming to the last topic, that is, what is the importance of this angle kappa? Okay, fine, we know that pseudoexotropia and pseudoesotropia might be there, but there are other applied aspects also when we talk about this angle kappa. Okay, the first thing you should know is there are tomographers which are available now, like the OpScan, which can actually measure this angle kappa. And this angle kappa has become very important in various refractive surgeries like the hyperopic LASIK, myopic LASIK. Even in case of presbyopia corrections, this angle kappa is being taken into consideration these days, okay, for the ablation purposes. Okay, second is in cataract surgeries, especially when they are putting premium IOLs like the multifocal IOLs, angle kappa is very important. In these refractive surgeries, wherever a patient has a large angle kappa, okay, what does it mean? A large angle kappa means there is a large deviation from the optical axis of the visual axis. That means if we put this lens, we will assume that the rays of light are passing through the center of the pupil and passing through the center of the IOL and giving a patient a crisp vision. But what is happening in a patient who has a large angle kappa? The light rays will not be passing through the center of the pupil. It will be passing somewhere here away, because the kappa angle is more. The visual axis and optical axis difference is also more. The light rays are going to pass through one of the rings of this multifocal IOL and not exactly through the center of this IOL, because of which the patient will have more amount of aberrations, and this multifocal IOL might not work for such a patient. So patients with large angle kappa, they do not have good results with refractive surgeries and also with specialized premium IOLs like the multifocal IOLs. I hope I made some points clear. Thank you. And coming to the MCQs over here, you can have a look at them and give me the answer in the comment section. Thank you and have a nice day.